hasn't started. लाइव कर दिया मैंने 5 मिनट पहले कर दिया. ये देखो स्ट्रीमिंग. हाँ
लिंक चेंज हुआ है.
हाँ
लिंक
लिंक तो दूसरा बनाया ना सर.
फिर ये वाला दो लिंक है.
सर तो मैंने तो स्टार्ट कर दिया ना. इट हैज़ नॉट स्टार्टेड.
वो लिंक और ये वाला लिंक अलग होगा ना फिर.
नहीं होगा ना सर. मैंने तो बनाया अभी. Why it has not started? लिंक तो दूसरा बनाया ना सर. सर तो मैंने तो स्टार्ट कर दिया ना. इट हैज़ नॉट स्टार्टेड. Good morning everyone. So I'm back again with part 2 of your Gynae revision, right? So yesterday we were talking about cancers, and as I told you, cancers is very important for your NEET PG, and that is why I'm taking it up in detail. Now let's talk about the management of ovarian cancers. For ovarian cancer, yesterday we had done the risk factors for ovarian cancer and the protective factors for ovarian cancer. And yesterday I told you that endometrial cancer and ovarian cancer, both of them are estrogen dependent tumors, right? And I also told you that all estrogen dependent tumors, जितने भी estrogen dependent tumors हैं gynae में, they are more common in obese females, they are more common in nulliparous females, they are more common in females who have early menarche, late menopause, right? And in ovarian cancer, I also told you one more very important thing, that there is the theory of incessant ovulation, which says that the more a female ovulates, more are the chances of her having ovarian cancer, right? So now let's continue with the management of ovarian cancer. In the management of ovarian cancer, one second beta, I'm unable to see your chats. That is why I'm just little woke. Where is the chat actually? I can't see your chats. Unable to get your chats. Just hold on. Just let me see why am I not getting your chats. One second. This is just... I told you yesterday na, that I am a person who's very technically handicapped, and that is why taking sessions becomes a little difficult for me because of my technical handicapness. One second. I'm just trying to see that why am I not getting your chats. Still unable to get your chats. So today we will have to go without chats. Oh, that's bad. That's bad. I'm unable to see your chats. Chalo, koi baat nahi. Without chats sahi. At least I know that you people are there and we can continue with ovarian cancer management. Right. Now when it comes to ovarian cancer management, प्लीज़ जैसे एंडोमेट्रियल कैंसर होता है ना, वैसे ओवेरियन कैंसर में भी यू हैव टू डू सर्जिकल स्टेजिंग. इफ़ यू रिमेंबर फॉर एंडोमेट्रियल कैंसर, व्हाट डिड आई टेल यू yesterday? For endometrial cancer, I told you that in endometrial cancer, in all stages, you have to do hysterectomy, right? Then you have to do lymph node dissection, and then depending upon whether the patient is low risk, intermediate risk, or high risk. In low risk, you don't have to give any post-operative radiotherapy. In intermediate risk, you have to give post-operative radiotherapy, and in high risk, you have to give chemotherapy plus radiotherapy. Same thing comes for ovarian cancer now. What you have to remember कि ovary is the most radio-sensitive organ, but on the other hand, ovarian cancers, they are radio-resistant except for dysgerminoma. तो ओवेरियन कैंसर में जब हम सर्जिकल स्टेजिंग करेंगे, आफ्टर सर्जिकल स्टेजिंग I am going to follow it up with chemotherapy. I cannot use radiotherapy, right? Now, what am I going to do in surgical staging? Very important. Many times this question has been asked. In surgical staging, number one, you are going to do a staging laparotomy. What do you mean by surgical staging? That I am going to do surgery and simultaneously I will stage the patient also. So for staging laparotomy, I am going to first, whatever ascitic fluid is there, I am going to collect it and I am going to send a sample of ascitic fluid. If there is no ascitic fluid, then I am going to add normal saline, I am going to do a peritoneal wash and I am going to send the sample. That's first step. Then I have to do surgery. What surgery? TAH plus BSO. In all cases of ovarian cancer, I have to do a TAH plus BSO. Then I have to take peritoneal biopsy. You have to take out peritoneal biopsy. Then you have to do infracolic omentectomy. Please remember, they are going to say all of the following steps are done in surgical staging of ovarian cancer except. उस except का आंसर होगा omental biopsy. I am not taking a sample of the omentum and sending it for biopsy. What am I doing? I am removing the entire omentum which is below the transverse colon, right? Infracolic omentectomy. So you do not do omental biopsy. Omental biopsy is not done. तो जब भी क्वेश्चन आएगा, all of the following steps are done in surgical staging of ovarian cancer except, उस except का आंसर most of the times is omental biopsy. Then you have to go for pelvic and para-aortic lymph node dissection. So in all cases of ovarian cancer, you do a TH plus BSO, you send peritoneal biopsy, you do infracolic omentectomy, you do pelvic and para-aortic lymph node dissection, and you send sample of ascitic fluid, right? Now this is how you do the surgical staging. Now before I go on to do the staging laparotomy or surgical staging, I am also going to do a CT scan because I have to plan कि मुझे करना क्या है. मुझे सर्जरी करने के बाद आफ्टर डूइंग सर्जिकल स्टेजिंग डू आई हैव टू गिव कीमोथेरेपी और आई डोंट हैव टू गिव कीमोथेरेपी. सो बिफोर यू डू अ सर्जिकल स्टेजिंग, to get a rough idea of the staging, exact staging you are going to know when you do the surgical staging, or that is when you do a staging laparotomy. But in order to get a rough idea of the staging, you do a CT scan. Now on CT scan, if you are getting the disease as stage 1 or stage 2, so stage 1 cancer or stage 2 cancer, stage 1 cancer, stage 2 cancers, this is what is called as early stages. Now management of ovarian cancer is very, very important, and I want all of you to note down this management in detail. Blank PDF of the session is available on CTG Telegram group and on SSS Telegram group, right? Now if it is stage 1 or stage 2, yes, I have to do surgery. That is, I have to do the staging laparotomy, all the steps of staging laparotomy, followed by chemotherapy. This chemotherapy I am going to give for 6 cycles, and this chemotherapy is called as adjuvant chemotherapy, right? What drugs am I going to use for chemotherapy? Carboplatin. So I am going to use a platinum based chemotherapy, carboplatin and paclitaxel. Carboplatin and paclitaxel. That's platinum based chemotherapy, right? Now plus minus bevacizumab, plus minus bevacizumab. Now please remember, bevacizumab has to be given only if your patient is BRCA negative. If she is BRCA negative, then only you have to give bevacizumab. Now if your patient is BRCA positive, if your patient is BRCA positive, you cannot give her bevacizumab. In that case, what are you going to give her? In that case, you are going to give her olaparib. Olaparib, right? So if your patient is BRCA negative, bevacizumab. If your patient is BRCA positive, olaparib. After you have given 6 cycles of your carboplatin and paclitaxel along with bevacizumab, Then you are going to put your patient on maintenance therapy. In maintenance therapy, you are going to give her PARP, P-A-R-P, PARP inhibitors, where PARP stands for poly-ADP ribose polymerase inhibitors. Poly-ADP ribose polymerase inhibitors, PARP inhibitors, and along with that, bevacizumab. Bevacizumab. Right? So this is how you manage in stage 1 and stage 2. If CT scan is showing that your patient is having stage 1 or stage 2 cancer, in that case, please first do surgical laparotomy followed by chemotherapy. In chemotherapy, 6 cycles of carboplatin plus paclitaxel along with bevacizumab plus minus. Bevacizumab only if patient is BRCA negative. If patient is BRCA positive, then olaparib. And this has to be followed by maintenance therapy. In maintenance therapy, you have to give PARP inhibitors plus bevacizumab. Right? Now, this is if your patient belongs to stage 1 or stage 2. Now, if CT scan is showing that it is advanced stages, it is advanced stage cancer, that is it is stage 3 or stage 4 cancer. Now you have to see whether the cancer can be resected or not. If cancer can be resected, you are going to go for cytoreductive surgery. Cytoreductive surgery means, this is also called as debulking surgery. What do you mean by cytoreductive or debulking surgery? Jitna remove kar sakte hain cancer, I'll remove that much of the cancer. Whatever cancer can be removed, I'm going to remove that. And this should be followed by chemotherapy, again, which is called as adjuvant chemotherapy, and again it has to be the same. Right? Carboplatin plus paclitaxel and plus minus bevacizumab. Clear to all of you? Now, if your ovarian cancer is not resectable, why will it not be resectable? Because either it is attached to a vital organ like liver or stomach or intestine, or if there is peritoneal spread, that is peritoneal caking, or if there is massive ascites. In that case, the cancer is not resectable. If the cancer is not resectable, in that case, first I am going to give chemotherapy. First, you have to give chemotherapy. This chemotherapy will be called as neoadjuvant chemotherapy. Right? So, have you understood the difference between adjuvant chemotherapy and neoadjuvant chemotherapy? Neoadjuvant chemotherapy is the chemotherapy which you give before surgery. Right? So, first I have to give chemotherapy. Again, I am going to use carboplatin and paclitaxel. Now, this time I am going to paclitaxel. This time I am going to give carboplatin and paclitaxel for 3 cycles. After I have given 3 cycles of carboplatin and paclitaxel, I am going to repeat a CT scan. And I am going to see, is the cancer resectable? Now, if the cancer is resectable, I am going to go for cytoreductive surgery. See, understand. Once you have given chemotherapy, the cancer size, the tumor size is going to shrink. So, a tumor which earlier may not be resectable might be resectable after 3 cycles of chemotherapy. That is why after 3 cycles, I am repeating the CT scan to see whether the cancer is resectable or not. And if the cancer is resectable, I am going to go for cytoreductive surgery. Now, after this, it will be followed by 3 cycles of chemotherapy. The remaining 3 cycles I am going to give after surgery. But if still the cancer is not resectable, then I am going to go for the 3 cycles, remaining 3 cycles of chemotherapy. In that case, I am not thinking about any surgery. Now I am going for remaining 3 cycles of chemotherapy. This is how you have to manage epithelial ovarian tumors. Clear to all of you? Very, very important is the management of epithelial ovarian tumors. Now, ovarian cancer in the management of ovarian cancer, they ask you about the platinum refractory tumors. What is a platinum resistant tumor? right, and a platinum sensitive tumor. So you should know these definitions. And for that, please understand that a patient who is a patient of ovarian cancer, whether you manage them surgically or whether you are giving them chemotherapy, monitoring of such patients have to be done with the help of CA 125 levels, right? Now, suppose if I am treating my patient on chemotherapy and I am monitoring her CA 125 levels, while my patient is on chemotherapy, I see that the CA 125 levels increase while my patient is on chemotherapy, right? This means that my patient is refractory to platinum. So this is called as platinum refractory tumor. Platinum refractory tumor, right? Why it is called as platinum refractory? Because the patient is not responding to platinum based chemotherapy. So if your patient is not responding to platinum based chemotherapy, you will definitely have to change the drug, and you are going to change the drug to PLD. What is PLD? That is pegylated liposomal doxorubicin. So instead of continuing with carboplatin and paclitaxel, now I am going to give her liposomal doxorubicin, right? PLD. Now, suppose CA 125 levels are not increasing during chemotherapy, but once I have stopped the chemotherapy, now patient's CA 125 levels increased. This is called as recurrent ovarian tumor. This is recurrent ovarian tumor, right? Or it can be called as relapse of ovarian tumor, right? So either you can call it as a recurrent ovarian tumor or a relapse of ovarian tumor. Now, if it is a case of relapse or recurrent ovarian tumor, now you have to see that management is going to depend upon the time of relapse, right? Whether the relapse is happening within 6 months of chemotherapy or whether the relapse is happening after 6 months of chemotherapy, right? This is what is called as platinum free interval. You have to look for platinum free interval. Platinum free interval. That means कि कितने टाइम के बाद आफ्टर स्टॉपिंग कीमोथेरेपी डिड द रिलैप्स हैपन, द प्लैटिनम फ्री इंटरवल. नाउ इफ प्लैटिनम फ्री इंटरवल इज मोर देन 6 months, in other words कि रिलैप्स इज हैपनिंग आफ्टर 6 months of stopping chemotherapy, that means this relapse is platinum sensitive. It's platinum sensitive relapse which has happened. And if it is a platinum sensitive relapse which has happened, I will continue with the same chemotherapy, that is carboplatin and paclitaxel. Again, I will put my patient on carboplatin and paclitaxel. But if relapse happened within 6 months, right, that means it is platinum resistant relapse. Platinum resistance relapse. If it is a platinum resistant relapse, please stop carboplatin. I will not give her carboplatin now, right? I will not restart her on carboplatin. I will restart her on paclitaxel and bevacizumab. Bevacizumab. Clear to all of you? So have you understood what is platinum refractory tumor? Platinum refractory tumor is if the tumor CA 125 levels increase while your patient is on chemotherapy. What is a platinum resistant tumor? Platinum resistant tumor is CA 125 levels are increasing after stopping chemotherapy but within 6 months of stopping chemotherapy, right? And what is a platinum sensitive relapse? Platinum sensitive relapse is if the relapse is happening after stopping chemotherapy, and after how many months of stopping chemotherapy? After more than 6 months of stopping chemotherapy, right? Now look at this question which had come in your exams. This is a PYQ. True about ovarian cancer recurrence. Platinum susceptible if recurrence is less than 6 months. If recurrence is happening at less than 6 months, is it platinum sensitive or platinum susceptible? No. Platinum susceptible का मतलब है if it is happening after more than 6 months. Partially platinum resistant, there is nothing like partially platinum resistance. Platinum resistant, if recurrence is happening at more than 12 months, platinum resistant कब कहते हैं? When do you call it as platinum resistant? Platinum resistant तब कहते हैं if it is happening at less than 6 months of stopping chemotherapy. So option D is the right option. Clear to all of you? Please, this is very, very important. Platinum refractory, platinum resistant and platinum susceptible. All these three definitions are extremely important for you, right? So that was the management of ovarian cancer. In ovarian cancer, I also want you to know what is Meek syndrome and pseudo-Meek syndrome, because you are very, very confused with that. Let's quickly revise. So in both Meek and in pseudo-Meek, you are going to get an ovarian tumor along with right side pleural effusion and ascites. You call it as Meek syndrome if that ovarian tumor is a fibroma, thicoma, Brenner's tumor or granulosa cell tumor. So if you are getting right side pleural effusion plus ascites, along with that there is an ovarian tumor which has to be any one of the four. Which four? Fibroma, thicoma, granulosa cell tumor and Brenner's tumor. You call it as Meek syndrome. When do you call it as pseudo-Meek? Pseudo-Meek का मतलब है any other ovarian tumor which is associated with ascites and with right side pleural effusion. It could be any other ovarian tumor or it can be any other condition like a fibroid. So even if a fibroid is associated with pleural effusion and ascites, you are going to call it as pseudo-Meek syndrome, right? Now, coming to tumor markers. Very, very important. In case of ovarian cancers, tumor markers are extremely important. Now, I know you remember the main ones, but other than the main ones, you have to remember which is not seen. So, I'll tell you an easy way how to remember it. So, first coming to dysgerminoma. All of you know that dysgerminoma is seen in dysgenetic gonads, and dysgenetic gonads का मतलब है they are not alpha males, right? Dysgenetic gonads हैं, so they cannot be alpha people. And if they are not alpha people, dysgenetic testes में हमें मिलते हैं dysgerminomas. अगर dysgenetic testes में I am getting dysgerminoma, right? So in that case, they cannot be the best males, they cannot be alpha males. So you are never going to see alpha fetoprotein as a tumor marker for dysgerminoma. Dysgerminoma में you are going to get low category males हैं ये. Low category male means L. L means LDH, right? And they are equivalent to females. That means HCG. So that is how I remember. Dysgerminoma is seen in dysgenetic testes. Dysgenetic testes means low wale males. Low wale male means LDH and HCG, right? And they cannot be alpha, so you will never get alpha fetoprotein in them. Then comes yolk sac tumor. Yolk sac tumor का मतलब Y chromosome is present. Y chromosome present है तो यानी कि proper alpha males हैं. अल्फा मेल्स हैं तो उनमें मेन कौन सा मिलेगा? अल्फा फीटोप्रोटीन मिलेगा. अल्फा मेल में कभी भी HCG मिलेगा? नहीं मिलेगा. दिस इज हाउ आई रिमेंबर इट. आई मीन दिस इज जस्ट अ वे ऑफ रिमेंबरिंग इट. So I will never get HCG in them. Yes, I can get LDH. So in yolk sac tumor, you are going to get alpha fetoprotein. You can get LDH, but you will never get HCG. Both alpha fetoprotein and HCG if you are getting, that means it's an embryonal cancer. In choriocarcinoma, you get only HCG, and in teratomas, you don't get any tumor marker. There is no tumor marker for teratomas, right? Now coming to staging of ovarian cancer. Staging of ovarian cancer is not important. At the most, I want you to remember 4 stages. Stage 1 में I just want you to remember 1C3. 1C3 means malignant ascites, right? Stage 2 में I want you to remember 2B. 2B means bladder and rectum involved. So सबसे पहले क्या याद रखोगे? 1. Stage 1 में कौन सी? C3. Only 1 C3. 1C3 मीन्स malignant ascites. स्टेज 2 में कौन सी याद रखोगे? 2B. B में क्या आएगा? ब्लैडर एंड रेक्टम. देन रिमेंबर 3A. तो 1 का C याद रखोगे, 2 का B याद रखोगे एंड 3 का A, 4 का A, लाइक दिस, राइट. 3 का A मतलब रेट्रोपेरिटोनियल लिम्फ नोड्स इन्वॉल्व एंड 4 का A मतलब प्लूरल इफ्यूजन. इज दैट क्लियर? 1 में यू हैव टू रिमेंबर C, 1C3 malignant ascites. 2 में कौन सा? 2B. B फॉर ब्लैडर, B फॉर B स्टेज 2B में ब्लैडर और रेक्टम. 3 में क्या याद रखना है? 3A. 3A का क्या मतलब है? रेट्रोपेरिटोनियल लिम्फ नोड्स इन्वॉल्व एंड 4 में भी A याद रखना है. 4A में प्लूरल इफ्यूजन, राइट. This is all what I want you to remember in staging of ovarian cancers and for management of ovarian cancer, the risk factors of ovarian cancer, the tumor markers of ovarian cancer, and I also just want you to remember some important images and histopath findings in ovarian cancer, which I will show you in the spotters just now. If you remember this much on ovarian cancer, most of your questions on ovarian cancer would be done. Right, I know ovarian cancer is a pain point for all of you, and that is why minimum what should have been revised in ovarian cancers, I have made you revise. Now, coming to vulval cancer. In vulval cancer, please remember that the most common type of vulval cancer is squamous cell cancer. Second most common type is melanoma. Right? Age group for vulval cancer is 50 years. Most common symptom for vulval cancer is pruritus, and the most common site for vulval cancer is labia majora, followed by labia minora. Now, in case of vulval cancers, again, remember the risk factors. Very, very important are risk factors. How are you going to remember it? Vulval cancer and ovarian cancer, vulval cancer and cancer cervix, both of them are caused by HPV. So here the mnemonic itself is HPVs, HPV and S, where H stands for HPV, and again it's HPV 16, which is most commonly responsible for vulval cancer. P stands for Paget's disease and P53 mutation. V stands for VIN, that is vulval intraepithelial neoplasias. V also stands for vulval dystrophy and vulval warts, right? So VIN, vulval dystrophies, vulval warts. Then S stands for lichen sclerosis and smoking. So HPVS, right? HPVs. H for HPV, P for Paget's disease, P for P53 mutation, V for VIN, V for vulval dystrophy, V for vulval warts, and S for smoking, and S for lichen sclerosis. Please remember which is not a risk factor for vulval cancer. Vulval hematomas are not a risk factor for vulval cancer, right? Vulval dystrophy is a risk factor, but not vulval hematomas. Clear? So if they give you all of the following are risk factors, except most of the times in except you will have vulval hematomas, right? Now, in case of vulval cancer, sentinel lymph node biopsy plays a very, very important role, and the sentinel lymph node for vulval cancer is superficial inguinal lymph node. Please remember that vulval lymphatics from superficial inguinal lymph node, they go into the deep inguinal lymph node, which is also called as femoral lymph node. That is why whenever I have to do lymphatic dissection, lymph node dissection in vulval cancer, it has to be inguinofemoral lymph node dissection. Inguinofemoral lymph node dissection. Now, one of the times in your questions, I think it was either in FMG or Neet PG, they had asked which dye is used for sentinel lymph node biopsy of vulval cancer. So, which dye is used? It is isosulfan blue, which is used for sentinel lymph node biopsy in vulval cancer, right? Please remember, pelvic lymph nodes are not involved in vulval cancer. That is why don't say in vulval cancer we do a pelvic and para-aortic lymph node dissection, जो कि हम रट के रहते हैं ना. Don't remember that. In vulval cancer, it has to be inguinofemoral lymph node dissection. In ovarian cancer, in endometrial cancer, in cancer cervix, it is pelvic and para-aortic lymph node dissection. An important point to remember is structures which lie within 2 centimeters of midline, their lymphatics cross, right? That is why if you have a vulval cancer which is within 2 centimeters of midline, you have to say that I will do a bilateral inguinofemoral lymph node dissection because the lymphatics are going to cross, right? Now, unilateral lymph node dissection. When do you go for unilateral lymph node dissection? Only if the size of the tumor is less than 2 centimeters, if the distance of the tumor from the midline is more than 2 centimeters and there is no local extension. Only if all these three conditions are fulfilled, all these three conditions should be fulfilled, then you have to go for unilateral lymph node dissection in vulval cancer. Otherwise, you have to go for bilateral inguinofemoral lymph node dissection. What are the three conditions? Size of the tumor less than 2 centimeters, distance more than 2 centimeters, and local extension absent. Right. A very, very important question which they can ask you is that we all know that vulva drains into all the organs which are present in vulva, all the structures which are present in female external genitalia. They all drain into superficial inguinal lymph node followed by deep inguinal lymph node, that is femoral lymph node. The only exception is glans of clitoris. Where does glans of clitoris drain? Glans of clitoris, it drains into lymph node of Clockway. Lymph node of Clockway, or which is called as Rosenmuller lymph node. Right? Now, how do you manage vulva cancer? Vulva cancer ka management is very much like cancer cervix. In cancer cervix also, yesterday I told you that up till stage 2A, you had to go for surgery. From 2B to stage 4, you had to go for chemoradiation. In case of vulval cancer, stage 1 and stage 2 में surgery, stage 3 and stage 4 में chemoradiation. If they ask you in which stage is lymph nodes involved in vulval cancer, in stage 3 and stage 4 lymph nodes are involved. In stage 1 and 2 lymph nodes are not involved. So जैसे ही lymph nodes involved होते हैं, we give them chemo radiation, right? Now coming to stage 1 and stage 2. In stage 1 and stage 2, I just want you to remember what is 1A and what is 1B. 1A का मतलब है if the size of the tumor is less than 2 centimeters and the depth of invasion is less than 1 millimeter. Please, this is very, very important. I don't want you to remember entire stagings, लेकिन जो stages मैं कह रही हूँ याद करने के लिए, you have to remember them. What is stage 1A in vulval cancer? Size of the tumor less than 2 centimeters and depth of invasion less than 1 millimeter. If the size of the tumor becomes more than equal to 2 centimeters or depth becomes more than 1 millimeter, then it comes in 1B. Either of these two criteria, जैसे ही size more than 2 centimeters हो जाए या depth of invasion more than 1 millimeter हो जाए, that means it is stage 1B. Now, as I told you, whether it is stage 1A or whether it is stage 1 or whether it is stage 2, always the management is surgery. In stage 1 and stage 2, management is surgery. Staging में you just have to remember this कि stage 1 and stage 2 surgery, stage 3 and stage 4 chemoradiation. Stage 1 में you have to remember 1A, 1B. उसका reason है because just now when we are talking about lymph node dissection, this information is going to come handy, right? Now, which surgery am I going to do? I am going to do radical partial vulvectomy, right? And I am going to remove the lymph nodes, right? Now, removal of lymph nodes में कौन से lymph nodes? The inguinofemoral lymph nodes. Which lymph nodes? Inguinofemoral lymph nodes. Only in stage 1A Instead of doing a radical partial vulvectomy, I can go for wide local excision of the tumor. Right? Now, how do you manage lymph nodes? If you are seeing that the lymph nodes are enlarged, right? Then in that case, please go for bilateral inguinofemoral lymph node dissection. Right? Lymph nodes enlarged hai, palpable hai, to go for inguinofemoral, bilateral inguinofemoral lymph node dissection. If lymph nodes are not palpable, right, remove a few lymph nodes and do a frozen biopsy of them, right? Now, and also do the staging. Now, if you see that it is stage 1A अगर ट्यूमर का है, then no lymph node dissection. So, every other stage में I am doing inguinofemoral lymph node dissection. If it is stage 1A, no lymph node dissection. Unilateral करना है कि bilateral करना है? अगर lymph node palpable हैं, bilateral. If lymph nodes are not palpable, initially go for unilateral inguinofemoral lymph node dissection, right? And once you've done unilateral inguinofemoral lymph node dissection, उसी समय do a frozen section. Frozen section की report दिखाती है कि nodes negative हैं, तो let it be a unilateral inguinofemoral lymph node dissection if the size of the tumor is less than 2 centimeters, if the tumor is more than 2 centimeters away, and if there is no local extension, right? अगर lymph nodes positive आ गए, then go for the contralateral lymph node dissection also, that is bilateral inguinofemoral lymph node dissection. Simplify करते हैं. Simplify में ये है कि in case of vulval cancers you have to go for inguinofemoral lymph node dissection. Stage 1A में, so I am simplifying it and writing for you. In vulval cancer you have to go for inguinofemoral lymph node dissection. Right? If nodes are palpable, अच्छा, in stage 1A, पहले लिखो, in stage 1A, no lymph node dissection. If the nodes are palpable, then bilateral inguinofemoral lymph node dissection. If nodes are positive, right, again bilateral inguinofemoral lymph node dissection. If nodes are not palpable, right, and they are not positive, in that case, only in this case, if following 3 conditions are fulfilled. What are the 3 conditions? The size of the tumor should be less than 2 centimeters. Tumor should be more than 2 centimeters from midline, plus there should be no local extension. Then you have to go for unilateral lymph node dissection. ठीक है? Have you all understood? The lymph node management in vulval cancer, कभी भी lymph node positive आए, bilateral inguinofemoral lymph node dissection. Lymph node palpable है, bilateral inguinofemoral lymph node dissection. ना तो lymph node palpable है, ना positive है, then I may think of unilateral lymph node dissection only if these 3 conditions are fulfilled. Stage 1A में no lymph node dissection. Very very easy management. Lymph node dissection को समझ लो. बाकी in vulval cancer there is nothing. In stage 1 and stage 2 surgery, stage 3 and stage 4 chemoradiation. Surgery कौन सी है? Partial radical vulvectomy, right? Stage 1A में only wide local excision and there is no lymph node dissection. सिंपल सा मैनेजमेंट है वल्वल कैंसर का. डन? चलो. नाउ कमिंग टू GnRH. GnRH के बारे में दे आस्क यू दैट व्हेन यू हैव सिंथेटिक GnRH you can give it in a pulsatile manner and you can give it in continuous manner. When you are giving GnRH in a continuous manner, it decreases LH, it decreases FSH, it decreases production of estrogen from ovary, and it also decreases production of androgens from the ovary. So in which conditions are you going to give continuous GnRH? I am going to give continuous GnRH whenever there is excessive estrogen. When is there excessive estrogen? It is there in fibroid. Fibroid is a hyperestrogenic condition. Then in case of endometriosis, in case of precocious puberty, right? Then where else am I going to give continuous GnRH? I am going to give continuous GnRH to decrease androgens. And when am I going to decrease androgens? In case of hirsutism, right? Then in case of estrogen positive breast cancer, and you can also give it to males in case of prostate cancer, right? Now, when it comes to pulsatile GnRH, pulsatile GnRH is going to increase LH, increase FSH, and increase estrogen. When are you going to use it? You are going to use it in patients of delayed puberty. You are going to use it in case of Kallmann syndrome, and you are going to use it in case of ovulation as an ovulation inducing agent. So in case of an ovulation, for treatment of an ovulation. So these are the conditions where you use pulsatile GnRH. Pulsatile GnRH is going to increase estrogen. Continuous GnRH is going to decrease estrogen, right? Then a few important things which you have to remember about selective estrogen receptor modulator drugs. The three most important selective estrogen receptor modulator drugs which you have to remember in gynae are clomiphene, tamoxifen, and raloxifene, right? Now, whether it is clomiphene, whether it is raloxifene, whether it is tamoxifen, all three of them, their side effect is hot flashes. And all three of them lead to vaginal dryness. Please remember this, right? Now, if they ask you what is the most common side effect of clomiphene, very, very important question. Most common side effect of clomiphene is, who's going to tell me? Don't say multiple pregnancy. It's never multiple pregnancy or twin pregnancy. Most common side effect of clomiphene is hot flashes, right? Then tamoxifen leads to, you remember we did family has old aunt as the risk factors for endometrial cancer, where T was tamoxifen. So tamoxifen leads to endometrial cancer. This question I told you yesterday also, that they ask you what is the time duration between tamoxifen and pregnancy. At least 2 months and ideally 3 months, right? Which serum is used in management of osteoporosis? Which serum is used in management of osteoporosis? Raloxifene. Now they ask you, can you use raloxifene for management of hot flashes? No. Please remember, raloxifene cannot be used in management of hot flashes because raloxifene leads to hot flashes. So you cannot use raloxifene for managing hot flashes. Raloxifene is used for managing osteoporosis, right? Which serum can you use for managing vaginal dryness? Tell me. Can you use clomiphene, tamoxifen, and raloxifene for vaginal dryness? No, because they lead to vaginal dryness. So which serum can you use for managing vaginal dryness? Tell me. Which serum? Ospemifene. Ospemifene. Which serum is used as emergency contraceptive? Ormeloxifene. Please remember, ormeloxifene is a component of centchroman. It's a component of centchroman. Centchroman is included in our National Family Planning Program with the name of, earlier it was Saheli, now it is Chaya. Pehle it was called as Saheli, now it is called as Chaya. So you have to remember that Centroman is included in our National Family Planning Program by the name of Chaya. If they ask you which SERM is used for hot flashes, which SERM can you use for managing hot flashes? Which SERM can you use for managing hot flashes? For managing hot flashes, you cannot use clomiphene, raloxifene or tamoxifen. You use a combination of bazidoxifene plus estrogen. It's a combination of bazidoxifene plus estrogen, right? Now, important points on menstrual cycle. All of you know LH surge is due to estrogen, right? What is the time duration between LH surge and ovulation? So this is your LH, this is estrogen. What is the time duration between LH surge and ovulation? It is 32 to 36 hours. Best answer is 32 to 36 hours. If that is not given, 24 to 36 hours. Right? Now, what is the time duration between LH peak and ovulation? What is the time duration between LH peak and ovulation? 10 to 12 hours. What is the time duration between estrogen peak and LH peak? Right? So what is the time duration between estrogen and peak and LH peak? This is 12 to 24 hours. 12 to 24 hours, that's the time. That's the time duration between your LH peak and estrogen peak. Now, coming to few important questions on corpus luteum. Tell me, corpus luteum of pregnancy is maintained by which hormone? Which hormone maintains corpus luteum of pregnancy? Just one change over here. This is not 12 to 24 hours. This is 14 to 24 hours. Right. 14 to 24 hours. Now, corpus luteum of pregnancy. Which hormone maintains corpus luteum of pregnancy? HCG. Which hormone maintains corpus luteum in a non-pregnant female? LH. What is the lifespan of corpus luteum in a pregnant female? Lifespan of corpus luteum in a pregnant female is approximately 10 weeks. Right? What is the lifespan of corpus luteum in a non-pregnant female? The lifespan of corpus luteum in a non-pregnant female is 12 to 14 days. 12 to 14 days. Right? If it is given 12 to 14 days, mark it as 12 to 14 days. Otherwise, the broader range is 12 to 16 days. Best answer 12 to 14 days. If that is not given, then a broader range is 12 to 16 days. Now, then comes a question, which is the most potent estrogen. Please remember that most potent estrogen is synthetic estrogen, that is ethinyl estradiol. Ethinyl estradiol. Right? This is followed by conjugated equine estrogen. Again, that's a synthetic estrogen. Right? Now, then this is followed by E2, that is estradiol, E1, that is estrone, and E3, that is estriol. Right? What is the estrogen which is most commonly used in OCPs? Most commonly used estrogen in OCPs is ethinyl estradiol. What is a high dose estrogen? A high dose OCP. Whenever we are classifying OCP as high dose, low dose, it is based on estrogen content. If ethinyl estradiol or if estrogen is more than 50 micrograms, then that is high dose. What is low dose? When ethinyl estradiol is less than 50 micrograms. Generally, it will be 30 to 35 micrograms. What is very low dose? If ethinyl estradiol is less than 20 micrograms. Which estrogen is used in HRT? It is 17 beta estradiol. 17 beta estradiol, that is the estrogen which is used in HRT, right? Now coming to absolute contraindications of OCPs. Please remember the absolute contraindications of OCPs are very, very important. You can understand them also because we all know that OCPs में estrogen है and progesterone है, and estrogen increases the clotting factors. That is why OCPs will be absolutely contraindicated in any female who has previous history of thromboembolism or history of MI or history of cerebrovascular accidents, right? Now, also because it has progesterone, it will be contraindicated in females who have previous history of breast cancer. Other than that, there are many other conditions where OCPs are contraindicated. You can remember them with the help of mnemonic. Banks have various schemes to provide home loans during May, where B stands for if it is your patient is a known case or a suspected case of breast cancer. H stands for uncontrolled hypertension. Please understand that if it is a medically controlled hypertension, then that's not an absolute contraindication for OCPs. Only if it is uncontrolled severe hypertension, right? So not even mild hypertension is a contraindication. Severe hypertension which is uncontrolled is a contraindication. Then any undiagnosed vaginal bleeding. If your patient has undiagnosed vaginal bleeding, if your patient is a smoker and she is more than 35 years of age, please understand any female who is more than 35 is not an absolute contraindication. Only if she is a smoker and if she is more than 35 years of age, then that's an absolute contraindication. Then if your patient has a known case or a suspected case of thromboembolism or cerebrovascular accidents or MI, right, then that means that's an absolute contraindication. If your patient is pregnant, obviously, then it's an absolute contraindication. Or if your patient has history of peripartum cardiomyopathy, which somehow is related to estrogen, that is why you don't have to give OCPs. Then if your patient has severe hypercholesteremia or hypertriglyceridemia, if your patient has abnormal liver functions, impaired liver function, or if she has history of liver cancer, or in pregnancy she has had cholestasis. Cholestasis is also precipitated by estrogen. That is why in patients who had cholestasis during pregnancy, you don't give them OCPs. Then diabetes with vasculopathy. Any diabetes is not a contraindication. Only if it is diabetes with vasculopathy, then that's an absolute contraindication. Migraine with aura is an absolute contraindication. If a patient is breastfeeding, then that's an absolute contraindication. Suppose if your question says patient is not breastfeeding. Breastfeeding females में OCPs is contraindicated. Why? Because OCPs में जो estrogen component होता है, it decreases the breast milk secretion. Now suppose I have a patient who delivered and she says that I don't want to breastfeed, right? I am going to use top feed. Can I give OCPs to her immediately after delivery if she is not breastfeeding? No. Still I cannot give her OCPs. Why? Because OCPs में जो estrogen होता है, that increases the clotting factors. And all of us know that pregnancy में भी the clotting factors are increased. So if I give OCP to my patient immediately after delivery, there are high chances of thromboembolism. I want her clotting factors to come back to normal, then only I want to give her OCPs. That is why in postpartum females who are less than 21 days, you cannot give them OCPs even if your patient is not breastfeeding. Clear to all of you? Very, very important. So coming to a PYQ which was asked in your exam, that is Neet PG 2019. Which of the following is an absolute contraindication to the use of OCPs? Chronic renal disease, thromboembolism, history of amenorrhea, and diabetes mellitus. As I told you, every diabetes is not an absolute contraindication. Only if it is diabetes with vasculopathy, that's an absolute contraindication. Renal disease is not an absolute contraindication. What is an absolute contraindication? Liver diseases, right? And yes, thromboembolism is a contraindication. History of amenorrhea, that's not an absolute contraindication. Only if your patient's UPT comes out to be positive, then that's an absolute contraindication. Clear to all of you? Yes? Okay. Now, very, very important is what to do in case of missed pills. Please understand, in case of missed pills for Neet, you have to remember the guidelines which have been given by Government of India. We strictly have to follow the GOI guidelines. Now, just I'm having water, 2 minutes. You also have water, and then I'll just tell you the missed pills protocol. Right. Now, all of you know that in pills, in a pack of pills, there are 21 hormonal tablets, which are the white colored tablets. And in case of Mala N and Mala D, along with the 21 hormonal tablets, there are 7 brown colored tablets, which are actually the iron tablets. Which iron does it have? It has ferrous fumarate. Ferrous fumarate. Okay? Now, Government of India, we are talking in terms of Mala N and Mala D because this is how we have to explain to our patients who are coming at PHC level. Right? Now, if your patient says that she has missed 1 or 2 pills at any time, you have to tell her not to worry. You have to tell her to take 1 pill as soon as she has remembered. So suppose today you get a call from a patient, Doctor Sahab, I've forgotten to take my pill of last night. So tell her not to worry. Abhi pill le lo last night wali. Right? And then continue your normal schedule. Right? There is no need for any backup method of contraception. So if 1 or 2 pills are missed, she has to take 1 pill as soon as she remembers, and then she has to continue her normal schedule without taking any backup. Clear to all of you? Right. Now, if your patient misses 3 pills, then you have to ask her, did you miss the pills in the first week, in the second week, or in third week? If she missed her 3 pills in first or second week, in that case you will have to tell her to take 1 pill as soon as she remembers. She has to continue the normal schedule. Along with that, she has to use a backup method of contraception for 7 days. So 1 pill as soon as she remembers, she has to continue the normal schedule, and she has to take a backup for 7 days. And just in case she had unprotected intercourse in past 72 hours, then she also has to go for emergency method of contraception. Right? Now, if she says, no doctor, I did not miss my 3 pills in first or second week, I missed my 3 pills in third week. Right? Up third week mein she has missed her 3 pills. Now you tell her, okay, it's okay. Now you have to take 1 pill at just now immediately. Continue the normal schedule. Take a backup for 7 days. Same thing जो हमने 3 weeks के लिए पहले किया था ना, 3 pills के लिए पहले किया था ना. That tell her to take 1 pill immediately, continue the normal schedule, and take a backup for 7 days. Now, other than that, what you have to tell her is that once her pack is over, she does not have to take these iron pills. The moment her pack is over, she has to discard that pack and she has to start the next pack immediately from the next day. Right? So after the hormonal pills finish, she has to throw the pack and she has to start a new pack the next day. Which means she is not stopping the pills at all. And if she is not stopping the pills at all, she will not have any periods. So just tell her that कि अब you don't have to take the brown pills. The moment your pack is over, start with a new pack, and that means you will not have any periods in this cycle. Clear to all of you? That is how you deal with missed pills. Yes? Now, coming to progesterone. In progesterone, I want you to remember what is the name of third generation progesterones. What are the names of third generation progesterones? There are 3 third generation progesterones: gestodine, desogestrel, and norgestimate. These are 3 third generation progesterones. Why am I telling to remember third generation progesterones? This is because progesterones the synthetic progesterones, as the generation of progesterone increases, the androgenic side effects of progesterone decrease. All those who have studied from me in Marrow and in DBMCI, you know that synthetic progesterones have androgenic side effects, which means synthetic progesterone can lead to hirsutism, right? So that means whenever I am using OCPs in a patient who has PCOS, I have to take special care that the progesterone should belong to third generation. What are the names of third generation progesterones? Gestodine, desogestrel, norgestimate, right? Now, third generation progesterones have least androgenic side effects. Fourth generation progesterones like spironolactone, like cyproterone acetate, these are anti-androgenic. Clear? I know my handwriting is bad. Just try to understand. Anti-androgenic. Okay? Now, coming to important point, LARC methods. Again, this is your PYQ. What are LARC methods? LARC methods are long-acting reversible contraceptives. In long-acting reversible contraceptives, 3 categories are included: DMPA injection, implants, and IUCDs. They come under the category of LARC methods. Questions have been asked related to DMPA. These days, DMPA has become hot favorite of INICT NEET PG. Now, DMPA is depomedroxyprogesterone acetate. The dose of depomedroxyprogesterone acetate is 150 milligrams. This is an injectable form. It has to be given IM and it has to be repeated after every 3 months, right? Now, this DMPA is included in National Family Planning Program with the name of Antara. What is the mechanism of action or the method of action? Please remember, whenever progesterone is present in high concentrations, its mechanism of action is it brings about an ovulation. And whenever progesterone is present in low concentrations, its main mechanism of action is it brings about thickening of cervical mucus. So in DMPA, progesterone is present in high concentrations. Whenever progesterone will be present in high concentration, it will have a negative feedback on LH and FSH, and so it brings about an ovulation. For DMPA, you have to remember, DMPA has 2 major advantages and 2 major disadvantages. 2 major advantages of DMPA is it decreases the seizure frequency. That is why if they ask you what is the contraceptive of choice in epileptic patients, contraceptive of choice in epileptic patients, your answer is going to be DMPA. What is the contraceptive of choice in sickle cell anemia patients? Again, it is going to be DMPA, because DMPA decreases the sickling in sickle cell anemia patients, right? Now, what are the disadvantages of DMPA? 2 major disadvantages of DMPA are it leads to a delayed return of fertility. Fertility can be delayed as long as 18 months after stopping the injection, right? And it leads to decrease in bone mineral density. Other than that, जितने भी progesterone contraceptives होते हैं, they have one problem, and that is they can lead to irregular bleeding, right? So yes, that is what you have to remember about Antara or DMPA injection. Now, as I told you, Antara or DMPA injection, it has to be repeated after every 3 months, right? And the window period is 4 weeks, right? Now let me explain to you that what you are going to do if a patient is missing her Antara injection. So I have brought 3 cases for you. This is exactly direct copy of Government of India guidelines. Number 1, if your patient who has had DMPA injection comes on exactly 3 months after the injection, if she comes on exactly the same date, just give her DMPA injection. No backup method is required. No backup method of contraception required. Now, second case is patient आती है 2 weeks earlier or up till 4 weeks later from the injection DMPA date. So DMPA था, suppose DMPA was given on 1st July, right? Now if she was given DMPA on 1st July, her injection date actually is August, September, October, right? So 1 month, 2 month, 3 month. Now exactly patient अगर 1st October को आ गई, I am going to give her DMPA injection without backup. Now I am saying patient comes 2 weeks earlier or within 4 weeks, right? 1st November से पहले आ गई patient, right? या 1st November तक भी अगर आ गई. So my patient is coming 2 weeks before 1st of October, or patient is coming up till 1st of November, right? In that case, I am again going to give her DMPA injection without any backup. But if my patient is coming after 1st November to get DMPA injection, in total how many months have passed now? In total, August तक 1 month, September तक 2nd month, October तक 3rd month, and November तक 4th month. So now if your patient is coming more than 4 months from the date of last injection, this is the time when I have to rule out pregnancy. If she is not pregnant, I am going to give her DMPA injection, and I am going to tell her to use a backup method like a condom for 7 days. Have you understood about DMPA injection? If your patient is suppose getting injection DMPA on 1st of July, right? This is when DMPA was given. Her due date is 1st of October. If she comes to me on 1st of October, just give her DMPA without any backup, without doing any UPT, right? Now, if your patient comes from 15th September to 1st November, again in that case I don't have to do any UPT. I have to give her DMPA injection, no backup required. But if my patient comes after 1st of November, that is more than 4 months after the injection, then first rule out pregnancy. If she is not pregnant, give her DMPA and tell her to use a backup for 7 days. Have you all understood? Well, what do you do with missed DMPA injections, or if the patient is coming exactly on the same time? These are 3 cases for DMPA which you have to remember, right? Now, in case of Neet PG 2020, this was an image which was given to you, and they had asked you identify this image. First identify this image. This image is a Fallop ring applicator, right? This has got 2 arms like this, and this is a Fallop ring applicator. This is used for laparoscopic sterilization, right? A few important points which I want you to remember about laparoscopic sterilization or laparoscopic tubal ligation is, which gas is used during laparoscopy. The gas which you are going to use is carbon dioxide. Pressure generators is 8 to 12 millimeters of mercury, right? Maximum volume of gas which can be used is 2 liters. Please remember, laparoscopic tubal ligation is never done in the postpartum period, right? It is never done in postpartum period. What do you understand by postpartum tubal ligation? What do you understand by postpartum tubal ligation? Postpartum tubal ligation का मतलब होता है if you are performing tubal ligation after 24 hours of delivery and up till 1 week of delivery. That is what is called as postpartum tubal ligation. Laparoscopic tubal ligation can never be done in the postpartum period. Why? Because if I do laparoscopic tubal ligation in the postpartum period, all of you know what is the height of the uterus immediately after delivery. Height of the uterus is just below the level of umbilicus. If uterus is present over here, if I am going to put a laparoscope, I will be perforating the uterus. So I cannot use laparoscopic tubal ligation for postpartum ligation, right? Laparoscopic tubal ligation is always done as a method of interval sterilization. What do you mean by interval sterilization? Interval sterilization means when tubal ligation is performed more than equal to 6 weeks in the postpartum period, or if you are doing tubal ligation in a female who was not pregnant. So either if she was pregnant and she has delivered and it is more than 6 weeks after delivery, or if she was not pregnant at all, both of them are called as interval sterilization. If they ask you what is the most common method of female sterilization, most common method of female sterilization is laparoscopic tubal ligation. But if they ask you what is the most common method of postpartum tubal ligation, as I told you, in postpartum period you cannot use laparoscopy, so you have to go with mini laparotomy. When I am doing mini laparotomy, I am going to make a loop of the isthmus. I am going to tie a suture over here and I am going to cut the loop. This is what is called as Pomeroy's technique, right? Laparoscopic tubal ligation or mini laparotomy is done in the isthmic area of the tube. Very, very important, right? What is the eligibility criteria for doing laparoscopic ligation? Eligibility criteria is that the age of the patient should be more than 29 years and less than 49 years. She should be married and she should have at least one child who is 1 year old. For tubal ligation, consent of female is only required. Husband's consent is not required. Another eligibility criteria is that husband should not have had a vasectomy. If husband has had a vasectomy, then it should be a case of failed vasectomy. Then only I can go for tubal ligation in the female. Now, suppose if your patient is mentally unfit, in that case, a certificate from the psychiatrist is required that she is mentally unfit, and in that case, consent can be given by the guardian, right? Now, if they ask you what is the eligibility criteria for vasectomy, vasectomy के लिए the age of the patient should be less than 60 years. Females में age should be more than 29 and less than 49. Males में age criteria is less than 60 years. Now, what is the qualification which is required to perform tubal ligation? Either the operating surgeon should have an MD or a DNB or a DGO in obs and gynae, or they can be plain MBBS or MS surgery, but then MBBS students or the registered medical practitioner or MS people, they should have assisted in at least 5 cases and they should have performed at least 5 cases of tubal ligation. So yes, tubal ligation can be performed by general surgeons also, but they should have performed they should have assisted in at least 5 tubal ligations and they should have performed at least 5 cases. This is the qualification which is required for performing tubal ligation. What is the qualification which is required to perform vasectomy? Anyone who is MBBS, anyone who has MS or MD, DNB, DGU, anyone can perform a vasectomy if they know how to perform it. right? Okay. Next about contraceptive was a question which was this. You cannot see the image. Actually, it's a very, very blurred image. I'll just make it for you. This is how the image is showing. And they have asked you identify the image. You have to identify whether it's a female condom or a male condom. I know all of you know this, that if two rings are visible, it means it's a female condom. And in this image, two rings were visible, so it has to be a female condom. Female condom can be FC1, FC2. FC1 was prepared from polyurethane. FC2 is prepared from nitrile, that is the most commonly used. Please remember the failure rate of female condoms is 5 to 20 per 100 women years, whereas male condom failure rate is less, it is 2 to 12 per 100 women years. Female condom is not included in National Family Planning Program. Male condom is included in National Family Planning Program by the name of Nirodh. Female condoms are distributed free of cost to female sex workers by NACO. And please remember, female condoms can be used maximum 2 times, but male condom can be used only once. When it comes to diaphragm can be used up till 1 year. So a female can wash and keep the dry and keep the diaphragm. Diaphragms can be used till 1 year. When it comes to today's sponge can be used maximum for 24 hours. During that 24 hours, multiple times it can be used. जैसे female condom can be used only twice, male condom can be used only once. But today's sponge का ऐसा नहीं है कि it can be used only once or twice. Maximum today's sponge can be kept in a female's body for 24 hours. And during those 24 hours, it can be used multiple times. That is why today's sponge is a very, very good contraceptive method for female sex workers. Right? Now, absolute contraindication for a female condom is rectocele and cystocele. Please remember, female condoms, like male condoms, protect against STDs. They protect against PIDs and ectopic pregnancy. They also protect against HIV and HPV infection. But yes, obviously male condoms are much better in preventing HIV transmission in comparison to male condoms, right? Whatever protection male condoms gives, same protection female condom gives, but the efficacy of male condoms is much more than the efficacy of female condoms, right? No barrier method can be used as emergency contraceptive. Clear to all of you? These are important points which you had to remember about female condoms. Now, coming to a question which came in Neet PG 2022, and this was the image given to you. You had to identify the image and you had to tell what is the absolute contraindication. So what is this image? This is copper T280A. Right? What is the other name for this? This is also called as Paragard. Right? So, coming to what are absolute contraindications for IUCDs. Now, when it comes to IUCD, whether it is copper IUCD and Mirena, the absolute contraindications are current PID, undiagnosed vaginal bleeding, and that undiagnosed vaginal bleeding could be due to endometrial cancer. So, endometrial cancer becomes an absolute contraindication. Cancer cervix becomes an absolute contraindication. Then gestational trophoblastic neoplasias, again they also present with bleeding, right? So that becomes an absolute contraindication. If there is a distorted uterine cavity, so any fibroid which is distorting the uterine cavity, that becomes an absolute contraindication, and suspected pregnancy. So these are absolute contraindications for IUCDs, whether it is copper or whether it is Mirena. Mirena is progesterone containing IUCD, right? Now, only for copper IUCD, the absolute contraindication is Wilson's disease, and only for Mirena, it is breast cancer, if there is history of breast cancer. Now, please remember, previous history of ectopic pregnancy is not a contraindication, and previous history of PID. Current PID is a contraindication. previous history of PID is not a contraindication for IUCDs, right? Then, a 24-year-old lactating female with 18 months child comes with history of irregular heavy bleeding, seeking contraceptive advice. What is the contraceptive of choice? Now, because your patient is coming to you with irregular bleeding, right? Progesterone containing contraceptives का खुद का side effect is irregular bleeding. So I will not prefer norethistron enanthate. I will not prefer progestasert. I will not prefer copper T380A. Why will I not prefer copper T380A? Because patient is complaining of heavy bleeding, right? Copper T itself leads to more of bleeding, right? So my answer over here is going to be Mala N. Now you are going to say that, ma'am, why Mala N? Why not Progestasert? पहली बात तो बेटा Progestasert is not used these days. It was withdrawn from the market because it led to very high chances of ectopic pregnancy if failure of Progestasert happened. Progestasert has been replaced by Mirena. Number 2. In this case, patient has 18 months old child, right? As I told you, OCPs can be used in females who are lactating after 6 months, right? Because OCPs will decrease breast milk. A patient ka baby is 18 months. Even if breast milk is decreased, hardly matters. So for irregular cycles, whenever there is irregular bleeding, always the drug of choice is OCPs, right? Over here the confusion was between Progestasert and Mala N. So I am removing that confusion, that because patient has 18 months old child, that is why I am okay giving her Mala N, right? Okay. Then, when to start contraception in a postpartum female? In a postpartum female, if the female is not breastfeeding or if she is partially breastfeeding, what do you understand by partially breastfeeding? Partially breastfeeding का मतलब होता है कि she is using top feed also. Then the contraceptive method should be begun from 3 weeks, and if a patient is properly breastfeeding, exclusively breastfeeding, then 3 months. That is what is called as rule of 3, right? Now, which contraceptives can be given from day 1 after delivery? Very, very important. Condoms can be used from day 1 after delivery. Scent Chroman can be used from day 1 after delivery, and progesterone containing contraceptives, which includes POPs and progesterone implants. What is the contraceptive of choice in lactating females? The answer is POPs, that is mini pills. Now, when can you insert IUCDs? Very, very important question. As I told you, postpartum tubal ligation. What was the definition for postpartum tubal ligation? Postpartum tubal ligation was when you were doing tubal ligation after 24 hours but within 1 week of delivery. Now, when it comes to IUCDs, these definitions are different. In IUCD, there can be post-placental insertion, beta, or it can be postpartum insertion, or it can be interval insertion. What do you understand by post-placental insertion? Post-placental insertion का मतलब है that when you are inserting IUCD within 10 minutes of delivery, right? When do you call it as postpartum IUCD insertion? Postpartum IUCD insertion is till 48 hours after delivery. Very, very important. And interval insertion is after 6 weeks. So government of India says that they encourage कि IUCD अगर insert करना है तो go for post placental or postpartum IUCD insertion. Before you discharge a patient, you should put an IUCD. So if they ask you what is the contraceptive of choice in lactating females, contraceptive of choice is POPs. If POPs is not given, then IUCD. In IUCD, I have to go either for post-placental IUCD insertion or postpartum IUCD insertion. If you do not insert the IUCD within 48 hours of delivery, then you have to wait for 6 weeks to insert IUCD, right? Now, OCPs. When can you start OCPs in a female who is breastfeeding? In a female who is breastfeeding, you can start it by 6 weeks after delivery. You can start, but ideally you should start after 6 months. If a female is not breastfeeding, you can start after 21 days, as I told you, but ideally you should start after 6 weeks, right? Now, DMPA injection. DMPA is progesterone. So, common sense tells me that progesterone injection can be given immediately after delivery. When I can put an implant immediately after delivery, when I can I can give injection after delivery. When I can put implant after delivery, when I can give her POPs, why not DMPA? I can give DMPA also if a female is breastfeeding. But should I give it? No, I should not. Why? Because I told you that DMPA is going to decrease the bone mineral density. And that is why in females who are breastfeeding, you should use it after 4 weeks of delivery. Remember this, very, very important point. DMPA should be used in a breastfeeding female. It should be given after 4 weeks of delivery. Similarly, if they ask you कि emergency contraception can be done, can be used after how many weeks of delivery? You can use it after 4 weeks of delivery. As I told you, laparoscopic tubal ligation is contraindicated in postpartum period. Mini laparotomy can be done in the postpartum period, and postpartum का मतलब होता है more than equal to 24 hours until 1 week of delivery. Mini laparotomy can be done in the postpartum period also, and it can be done as a method of interval sterilization also. Right? Now, next question was related to your emergency contraception. Very, very important is emergency contraception. In Neet PG 2019, they had asked what is the dose of ulipristal used in emergency contraception. Option A 30, option B 30 milligrams, option B 300 milligrams, option C 60 milligrams, option D 600 milligrams. So what is the dose which you can use? Please remember it is 30 milligrams. Now, or the emergency contraceptives which are used, most commonly used is levonorgestrel, right? Levonorgestrel, the government of India जो levonorgestrel को advocate करता है, that is single dose of 1.5 mg, which should be given within 72 hours of unprotected intercourse, right? You can give a single tablet of 1.5 mg, which is most commonly distributed by Government of India, and it is available in the form of iPill as well. But yes, it can be divided into two also, 0.75 mg stat and after 12 hours 0.75 mg. But what is most commonly used is single tablet 1.5 mg. Then you can use OCPs. When OCPs are used for emergency contraception, it is called as USPs method, where you tell a patient to take 2 tablets stat and then after 12 hours 2 tablets. Then they can use copper IUCDs. Copper IUCDs are most effective method of emergency contraception. Most effective method of emergency contraception, and they can be inserted within 5 days after unprotected intercourse. They are not suitable for rape victims, right? Then comes centroman. Again, centroman can be used as an emergency contraceptive. The dose is 60 milligrams. Ulipristal can be used. 30 milligrams is the dose, and it is the most effective hormonal contraceptive. Ulipristal can also be, ideally it should be given within 72 hours, but you can use it up till 120 hours. That is up till 5 days you can use ulipristal. Mifepristone single dose 10 to 50 mg single dose. So these are the drugs which are used as emergency contraceptives. I am repeating: levonorgestrel, OCPs, centroman, then your mifepristone, ulipristal and levonorgestrel. These and IUCDs. These are the drugs which are used as emergency contraceptives. Drugs which are not used as emergency contraceptives, just because you are using levonorgestrel, don't think that POPs can be used. Just because copper IUCD is used, don't confuse it with Mirena, that Mirena can be used. No, Mirena cannot be used as emergency contraceptive. Just because mifepristone can be used, don't confuse it with misoprost. Misoprost cannot be used as emergency contraceptive, and danazol cannot be used as emergency contraceptive. Right? So, which of the following is not used as emergency contraceptive? Just now I told you, remember 4 drugs not used. POPs, Mirena, misoprost and danazol. So, what is the answer? Danazol. Danazol cannot be used as emergency contraceptive. RU486 is the other name for mifepristone. Right? Now, what is the mechanism of action of emergency contraceptive? Now, if they ask you what is the mechanism of action, best answer for mechanism of action is that they delay ovulation. Please don't say that emergency contraceptives bring about an ovulation. No. When we are using levonorgestrel, again, for levonorgestrel also, the best method for preventing, for bringing about contraception is that it delays ovulation. If delays ovulation is not given in the option, then you are going to say the second best answer is it delays fertilization, right? But if it comes to IUCDs, please remember, and first of all levonorgestrel. Levonorgestrel ka best action is it delays ovulation and it delays fertilization. Levonorgestrel has no effect on implantation and it is not an abortifacient. When it comes to copper IUCDs, because copper IUCDs will release copper, they prevent implantation. Levonorgestrel does not prevent implantation. Levonorgestrel acts only by 2 methods, in which the most important one is it delays ovulation and number 2, it delays fertilization. IUCDs, yes, they prevent implantation, right? Okay. Then, I hope it is clear till here. Today I can't read your chats and that is why it is becoming so difficult for me. I am unable to read your chats. So this completes your contraception. This completes your cancer all the cancers. So revision related to cancers is over. Revision related to contraceptives is over. Right? Now I have to talk to you about revision related to prolapse, revision of amenorrhea, all these topics which are there. We have reached half of the discussion now. Now I am going to take a break because I have another class. After the class, I am going to resume this discussion. This discussion I am going to resume at 4 o'clock. At 4 or 5, I'll just inform you on the group depending upon when my class is getting over. I will resume the Gynae. So that will be the last part of Gynae discussion, that is Gynae part 3, right? So Gynae revision is in 3 parts. Part 1 we did yesterday, part 2 I have done just now. Now I have a class to take. After the class, I am going to do Gynae part 3, right? I will inform you on CTG group. I will share the link on CTG group that at what time. Either it is going to be 4 or it is going to be 5, right? Okay. See you in Gynae part 3.